Hi, I'm here today to talk about disc herniations in the neck. A patient will typically present with a deep achy pain in the neck. It can be sharp or burning, even include numbness and tingling on down the upper extremity in a dermatomal pattern. Other signs and symptoms may include paresthesia, antalgic lean, decreased range of motion, and muscle hypertonicity. This condition can be aggravated by coughing, straining, and sneezing. There are two basic types of herniations. Lateral herniation will cause a ipsilateral pain on the side of the herniation, and a central herniation will cause bilateral pain. The anatomy involved in the herniation, the disc has a couple parts to it. It has the nucleus pulposa, which is surrounded by the annular fibers, which are crisscrossed to hold in the gelatinous nucleus pulposa. The job of the disc is to act as a shock absorber as well as a fulcrum for motion in the spine. The disc itself is contained by the ALL, PLL, and the ligamentum flavum. If the disc herniates, it can affect the spinal cord, nerve roots, and/or facet joints. The herniation may be broad or focal. A broad-based hernia is considered to cover more than 25% of disc space, whereas a focal herniation covers less than 5% of disc space. Herniations can be protruded or extruded. A protrusion herniation is one that is wider at its base than the distance it projects, and an extruded herniation projects further than the width of its base. A contained herniation is one that is still held within the annular fibers even if the fibers are bulging, and an uncontained herniation is one that has pressed completely out of the annular fibers. A herniation with a free fragment is also known as a sequestered fragment, is where there is a remaining continuity between the actual disc and the portion of the nucleus that is protruding outside of the herniation. Another type of herniation is also called intervertebral, aka Schmorl's node. This is a protrusion of the disc onto the adjacent vertebrae, and it kind of affects the bone there. On an x-ray you can see a little sign. Schmorl's nodes are most common in the thoracic and lumbar spine. The pathomechanics of herniation are: younger people tend to have herniations, and older people tend to just have disc degeneration. This is because as people age, the discs dry up and there's nothing left to herniate. So, as I said, younger people have herniations. You can have a variety of symptoms. Herniation can narrow the IVF and create a posterior shift that also leads to degeneration. The degeneration can lead directly to spinal stenosis and nerve root irritation and inflammation. In fact, inflammation is the #1 cause of myelopathy. The onset of herniation could be insidious, such as poor posture for a long time causing micro tears, or could be traumatic in the case of a motor vehicle accident. A few things that you might do to check out your patient if they come into your office: you can do x-rays. In the case of trauma, they're also good for ruling out degenerative joint disease and foraminal encroachment, and they also allow you to see disc space and potential postural changes in your patient. MRIs are great for seeing the size of disc herniations as well as soft tissue lesions. And if you have extreme bony changes, you might want to get a CT done. They seem to be the best in that case. To test my patient, I'm going to do an orthopedic test known as Jackson's compression. I'm going to laterally flex the head over to compress the IVF, compress the nerve roots, and see if there's any irritation. So if you're okay, we'll do that test now. First test, just put your hand on the patient's head and just press straight down. Is there any pain with that? Then you want to bend the patient laterally and keep your hand kind of over the midline of the spine. You don't want to be over here pressing down, you want to be more here. Down. Any pain with that? Then you check the other side, move the patient's head down. Any pain with that? Excellent. By pressing down, I'm compressing the nerve root and the disc and trying to irritate it. If there was any irritation, the patient would probably say, yeah, that hurts, please stop. The positive Jackson's test will produce, the pain will be on the side of the compression because, like I said, you're narrowing the space and compressing the nerve root, closing off the facets. This would be an indication, a positive indication of a nerve root pathology. To help in my differential diagnosis, I would also perform Valsalva's test to check for a space-occupying lesion. Allen's test would help rule out a brachial plexus pathology. And Lermiti's would help me rule out myelopathy. To manage a patient's care like this, if it was acute and they came in, you could offer them some ice, maybe anti-inflammatories. Recommend that they might look into anti-inflammatories. You might do ultrasound, maybe even TENS unit therapy. In a less acute stage, you could adjust the patient or mobilize them as their pain threshold will allow. You can also do myofascial release and some stretching. I think that covers it. Thanks.